subscribe now and press the bell icon. Never miss an update.
Hello and welcome to Health Live at Seniors Today. We have here with us Dr. Mudit Khanna, who is a leading consultant, orthopedic trauma and joint arthroplasty at the Wockhardt Hospitals in Mumbai. Dr. Khanna graduated from the prestigious King George Medical College in Mumbai, where he completed both his M.B.B.S. and M.S. in orthopedic surgery. Most of his higher surgical training in orthopedic surgery has centered around gaining expertise in the field of joint replacement in the United Kingdom and other reputed centers across Europe, US, and Australia. While pursuing his higher surgical training in the field of orthopedic surgery in the UK for a period of 5 years in various capacities, he completed his M.R.C.S. from the Royal College of Surgeons of Edinburgh and M.Ch in orthopedic surgery from University of Dundee in Scotland. He has worked as a senior clinical fellow at the Queen Elizabeth Hospital in the UK and was awarded the Asia Pacific Zimmer Fellowship, which he pursued at the renowned Cleveland Clinic in Ohio in the US. He has expertise at performing all forms of primary and revision joint replacement cases and is a trusted name at handling complex sports-related injuries, including arthropedic treatment. Dr. Khanna has a number of national and international publications to his credit. He has also been teaching extensively and has authored 2 highly acclaimed books in the field of postgraduate studies. He is a member of the Royal College of Surgeons of Edinburgh and the Indian Orthopaedic Association. Delighted to have you here, Dr. Khanna. How are you?
Thank you. Thank you very much for inviting me over. It's a pleasure to be here. Thank you for this wonderful introduction.
It's our pleasure that you are here. Dr. Khanna, one of the questions which I always ask people, and because, since we started the webinar series around 90 weeks back, the pandemic has hit us. And since you are at the Wockhardt Hospitals in Mumbai, what do you see is the situation on the ground as of now?
So talking about COVID, essentially, I can only tell you that the number of patients coming into the hospital with COVID is probably at its lowest at the moment. So the number of, I think we've closed most of our wards. Probably just one ward is now still open for COVID patients, but overall the numbers are coming down significantly. And I think this wave overall has been the mildest so far. Majority of patients did not need hospitalization, and I think very, very, very few ended up needing the ICU at all. So I think this wave probably moves us a little, that's my personal opinion, but moves us a little closer to assuming that, probably we're going to be seeing this as a seasonal flu. I would want to believe that, and hopefully we can get over the pandemic and, like some countries have done, get rid of the masks that we've been wearing and sort of get back to socializing and good food.
And but you must be obviously still having your mask on.
Absolutely. So I'm not taking anything away from the due precautions that we should be taking. I by no means suggest or recommend that we do not use masks. I think hand washing and masks are something that everyone should be using, and sort of not take it easy on that account. Yeah.
We're getting to March very soon, and if you remember, Mumbai had seen a huge second wave last year. So is there any reason for concern?
It was February, March the first time. It was February, March the second time. And we were assuming that it is going to be February, March this time. But I think the worst, it probably came a little earlier this time. So I'm hoping that, we won't see that in this Feb, March. Yeah. We've already seen the third one. So I think we can take it easy for the coming year.
Fingers crossed, and let's hope things are okay. Over to you, Dr. Khanna, for your presentation. We requested Dr. Mudit Khanna to speak about joint pain and knee problems for senior citizens. And I was telling him that the kind of response we received to this is excellent, but it's also a little worrying because we've had sessions on orthopedic half a dozen times, and it just shows there are so many concerns around the issue. So over to you for your presentation, and then we will have questions. As always, those of you who have questions, please put them in the Q&A tab. Mention your name. Well, if you want, we can you can avoid mentioning your name. You can keep it anonymous, but do mention your gender as well as your age for Dr. Khanna to give you a considered response. Over to you, Doctor.
Thank you very much. So I'll start my, I'll just share my screen, and I'll start off with the presentation. If there's anything that is not clear, please do not hesitate to stop me in between in case required. Okay, so now I will be talking today essentially about osteoarthritis of the knee, and my objective is to make everybody understand what it really means, and what are the treatment options, and whether there is something we can do to prevent osteoarthritis. So essentially, if you look at the knee is made up of two bones, the thigh bone or the femur, or the shin bone or the tibia. So the joint essentially is the area that lies between the two bones. It is not the bone itself, it's the area between the two bones. Now at the end, every bone in the body where two bones sort of meet and form a joint, the ends of these bones are covered by a very, very smooth and soft cushion known as cartilage. Now to understand what arthritis is and what osteoarthritis is typically not a problem of the bone. Osteoarthritis is a problem of the cartilage that covers the ends of these bones. So what does osteoarthritis mean? Osteoarthritis means that over a period of time, somebody may end up losing the cushion or the cartilage that covers the ends of these bones. And as the condition progresses, they may end up losing it completely, such that the bone at the top starts grinding with the bone at the bottom. And that is what osteoarthritis essentially is. What we have to understand is that osteoarthritis is a common term used for early stages as well and for advanced stages as well. But typically the progression of, so if you look at the cross section on this image, this thick layer of cushion is the cartilage. In early stages, there is some fraying of the cartilage. This is also known as osteoarthritis, but it is grade 1 or 2. And as time progresses, the layer of this cartilage goes off completely, and that is grade 4 arthritis or bone-on-bone arthritis. Now, our objective typically is to delay the progression of this arthritis from grade 1 to grade 4. Once it reaches grade 4, that means there is bone-on-bone arthritis, and the treatment is primarily surgical. I will skip these. Now, how common is osteoarthritis? Osteoarthritis is a very, very common condition. 1 in 2 people will develop osteoarthritis by the time they reach the age of 70. And 2 in 3 people who are overweight or obese will develop osteoarthritis by the time they reach 70. It is the lifetime risk of developing osteoarthritis in the knee is greater than the lifetime risk of developing diabetes. So that is how common this condition is. Now, how do we diagnose whether a person has osteoarthritis or not? So the first symptoms of osteoarthritis, or the primary symptom of osteoarthritis, is pain. When osteoarthritis starts, this pain is typically only at certain times, not throughout the day. The initial symptom is that when somebody is seated for a long time in one position and then gets up, for example, you're sitting on the dining table having your meal, and then you get up and start walking, you develop some pain in the knee. The pain is initially there for the first few steps, and then you are fine. Similarly, there may be some trouble getting in and out of the car. So if you've been on a long drive, get out of the car, start to walk, that's the time you observe pain. And after you walked a few steps, it becomes all right. Some people may notice this pain while climbing up or climbing down the stairs. Now, these are subtle signs to indicate that osteoarthritis may be developing, especially in patients who've had no history of trauma or injury. The second symptom is deformity. So there are two kinds of deformities that we see in the knee, the knock knees or the bow legs. Now, and that really depends on which part of cartilage of which part of the knee has worn out. If the inner part of the knee wears out, the deformity that develops is bow legs, which we call varus. This is the most common type. If the cartilage wears out from the outer side of the knee, we get a valgus knee or knock knees typically. So if you see these images, these patients have bow legs. Sorry about that. Give me a second. And these knees are valgus or knock knees typically. So these are the deformities that we see typically in advanced stages of osteoarthritis. The third symptom or sign of osteoarthritis is instability. Instability typically means the knee is a hinge joint. It should only be moving in one plane. The job of the knee is only to flex and extend. If the knee starts moving side to side, it becomes instability in the knee, and that should not be happening. Okay, so if a patient has pain, if a patient has deformity, and if the patient has instability on clinical examination, then there is obvious that the patient is developing arthritis. We typically don't even need an investigation to confirm that somebody has arthritis, but the only investigation we look at is a plain X-ray of the knee. And if you can spot arthritis on a plain X-ray, then it is bad enough to suggest bone-on-bone arthritis. Now, if you see here, this is an X-ray, and what we see here is that there is bone at the top, bone at the bottom, and there is no space between the two bones. So this is bone-on-bone arthritis. And when arthritis sort of progresses over a stage, we can get bad-looking X-rays, which are typically seen when somebody has left bone-on-bone arthritis untreated for a much longer time. Now, this is how we understand what arthritis is. Now, what can we do about osteoarthritis? Now, typically and unfortunately, there is no magic medication that we can give someone and tell them that you take this medicine and you'll be all right. So in a way, osteoarthritis is a wear and tear degenerative process that happens over a period of years. Some form of, it's not directly related to age, but it's in a way could be understood as an aging process of the joint. So when we consider osteoarthritis or look at osteoarthritis as an aging process of the joint, what we really need to understand is that, you can't expect the doctor to give you some medicine that will magically cure the arthritis. The only thing that we look at when somebody has arthritis is trying to delay the progression of arthritis. So prevention of progression of arthritis is the best treatment strategy for treating osteoarthritis. Once somebody develops bone-on-bone arthritis, unfortunately, the only treatment option that is available is a surgical option, and the surgical option is known as a total knee replacement surgery. And a total knee replacement surgery, I will also explain, is not a transplant. It is not that we take the knee out and put a metal knee in. Total knee replacement is a misnomer in a way. In total knee replacement, what we typically do is to put a cap on the bones. So the lower end of the top bone is capped, the top end of the bottom bone is capped, and then an artificial cushion is slid in between. It's something similar to what the dentist does when somebody has a crown fitted on top of their tooth for pain in the tooth. So it's not a transplant. It is not a true replacement either. It's a procedure wherein the ends of the bones are capped and the alignment of the knee is restored. So a bowed knee, whether it's a knock knee or it's a bow leg, both of them are aligned back straight. There are different forms of replacement that are done. So there is something known as a partial knee replacement. The knee typically has 3 compartments. So if only one compartment is bad and all the ligaments, everything is good, we do what is known as a partial knee replacement. As you can see, there is a small metal cap only on the inner side of the knee. If the knee is bad overall, we put a sort of a cap extending through both the compartments. And if it's really bad, we might end up sometimes needing a special implant with a lot of metal work, as you can see, with the rod going up and down to treat these patients. Now, I will sort of take you through a couple of videos to understand what is done. So as you can see, this gentleman is walking with difficulty. It is obvious that he is in pain. We can also see that there is an obvious deformity in the knee, and what he has is a varus deformity, or the knees are sort of bowed. So diagnosis is very clear. We will do an X-ray to confirm the diagnosis. But if somebody comes into the clinic walking like this, and even walking half as bad as this, we would know that the patient does have arthritis in the knee. Now, when we look at the X-rays, there is complete sort of loss of joint space. The bone at the top is rubbing with the bone at the bottom. What we've done is a knee replacement surgery where we've sort of capped the ends of the bones and slid a cushion in between. The knee remains the patient's knee. Now we see him walking post-operatively. And if we see him walking post-operatively, the alignment of the knee is restored. It is the same gentleman, but now the knees are looking much more normal. We did the first one about I think 3 months ago, and it's been probably 4 to 6 weeks since the other side. So you can still spot a bit of swelling on the other knee, but this will also resolve, and he will end up feeling completely normal. Now, if somebody at that stage also leaves the arthritis unattended, the arthritis can get more bad. And this is not a pleasant sight to watch, but it's important to understand that we shouldn't be leaving a bone-on-bone arthritis for too long, because it makes the surgical task a lot more complex, and the prognostic outcome in terms of how long a knee replacement will last is reduced. Now, if you look at his X-rays, he had bone-on-bone arthritis and continued to walk on it. So he broke this fragment of bone. And once you don't have a base to put a tray on, you end up needing a more complex former for replacement like this. Even such bad conditions, however, can be managed. This is him, I think, again, 4 to 6 weeks after the procedure when they come to us for the first follow-up. And you can see, though there is swelling, the alignment of the knee is restored, and he's able to walk much more better. I think I will not take you through more. This is another gentleman with a valgus knee, but I won't take you through this. I will just talk about when somebody should consider joint replacement surgery. So essentially, joint replacement surgery should be considered when two things are there. When the X-rays shows bone-on-bone arthritis, complete loss of cartilage, not when half the cartilage is lost, when the cartilage is lost completely, and we can see bone rubbing on bone, so that is one requirement. The second requirement is that there should be significant enough pain to interfere with somebody's quality of life. So if somebody has developed bone-on-bone arthritis, but is still able to do all his normal activities with minimal pain, then that person can surely wait and delay a knee replacement surgery. But if the arthritis is bad and there is significant pain, then that is the right time to do a procedure. There are tools to assess how bad somebody is, because some patients are not able to sort of explain themselves in terms of how bad their condition is. So when something like this happens, then we have an Oxford knee scoring system. And with this scoring system, we can assess how poorly that person is performing. In a nutshell, I will sort of explain that the knees should be treated when there is complete loss of cartilage, whether on half the knee, on the entire knee, but it shouldn't be left to a stage like this when the knee is completely bad. And if we can treat them at stages like this, we can give much better, excellent results. We are likely to see happy and smiling patients. This is a lady 2 weeks after the procedure, showing off some of her dance steps. We have another lady after having both knees replaced. She's back in her country. These are international patients who've come to us and shared their videos after going back. So I think with the time that we have, I would stop here and open it up for questions. Um,
Thank you
and
very much, Doctor.
I hope that I was able to sort of explain what osteoarthritis really is. Thank you. Yeah.
Thank you. Excellent presentation, Doctor. Once you,
Should I?
yeah, if you could just stop it, and I will then. Great. Thank you. We have quite a few questions that have come in, and I'm going to start taking these. There's a question from Bharat Mehta, who asks, is there any new technique where the knee is not replaced? Effect of uric acid for bone problem?
So the answer is there are a number of techniques that we are working on to delay the progression of arthritis. We are working on things. So we're working on sort of things within the stem cell family or regenerative medicine. Let's put it like this. There are the options of growth factor concentrate injections that can be given into the knee. There is platelet-rich plasma that is given into the knee. There are bone marrow concentrates that are given into the knee. Now, this is an entirely different topic, but what somebody needs to understand is that these treatment options need to be started early to delay the point where bone-on-bone arthritis develops. If bone-on-bone arthritis has already developed, at this stage, none of the available treatment options will work. But if somebody diagnoses the condition early, then we may be able to delay the need of a replacement by several years, and maybe somebody then does not end up requiring a knee replacement altogether.
Right. We have a question from Poonam Chand Wagmare, who says, who asks, what will be the side effect of long sitting? Is there any side effect of sitting for a long time?
Typically there is no side effect of sitting for a long time as such, but it's important that we keep moving all our joints, not just the knees, but all our joints frequently enough. So if you look at the recommendations, if somebody is on a desk job, etc., we now recommend that they get up sort of every few minutes, half an hour maybe, and move around. Now, moving the joints helps to lubricate the joints and help to keep the joint functional. It also helps with the muscle memory and the muscles as such. So, I mean, if you ask a fit and healthy joint, if somebody is sitting with a fit and healthy joint for a long period of time, typically there isn't a problem. But the long period of time needs to be defined. If you're talking about 6 to 8 hours, somebody sitting, then that's what I think so many kids do when they go to school. So, I mean, really nothing to worry about. But a bad joint, an arthritic joint, if somebody sits for 6 to 8 hours, will become stiff and they will struggle a lot more to walk when they start walking.
Right. I have a few questions which are very specific. There's a question from Surinder Mahajan, who is 76. And his question is, he's saying, during routine blood tests about 6 months back, my vitamin D level was 27.47, as against normal limits between 30 to 100. The doctor advised me to have D-Rise 60K capsules. I have consumed 8 capsules, 1 capsule every week of D-Rise 60K. In addition to this, I was taking 1 tablet of Daily Cal OK every day. Will it be okay if I repeat this medicine? Please also advise how long should I continue with this? He is 76.
Okay. So I answer it in short. I will answer it in short. The requirement of vitamin D levels is about 1,000 units a day. if somebody is deficient in vitamin D, we recommend 60,000 units once a week for 8 weeks to take care of the deficiency. Once the deficiency is taken care of, we want you to maintain a daily intake of about 1,000 units of vitamin D every day. Now, you can do this by taking supplements that come in 1,000 units, or you could do that by taking a 60,000 unit tablet, the Uprise D3 or the D-Rise D3, whatever you have, once every 2 months. So basically, it's 60,000 units that you have with you. You need 1,000 units a day. You can do the math yourself.
And what about walking in sunlight, for instance?
So the source of vitamin D is sunlight itself. For whatever reason, which are not very, very clear, if we sort of look at 10 patients, 10 random people walking on the road at the moment, and we sort of get them and make them do their blood tests and check for the vitamin D levels, we've perpetually observed that 8 out of those 10 are going to be deficient in vitamin D. Now, if you ask me what is so I would still think that either we're not getting the quality of sunlight that we need, or we're not getting the desired time of sunlight that we need. And that's why most people are still deficient in vitamin D. But early morning sun, for half an hour, if you're in the sun, that should also help improve your vitamin D levels. The way to check it is, however, to repeat the vitamin D levels at the end of the course and see how they are faring. It is not a good idea for the vitamin D levels to come, rise, drop, rise, drop, rise. The best way it works is to keep them steady at the required levels.
Right. Thank you. We have a question from Mr. Gurdeep Shaw, who's 65. He's asked, why do some joints make a little noise in movement? What can we do to avoid this noise?
So, we shouldn't be worried about painless noise in the joint. Okay, so the noise in a joint can be classified into a painless sound and a painful sound, which means that every time the joint creaks or clicks, you get pain. Now, that is an indicator of an underlying problem. You probably need to have an MRI or an X-ray to understand why this is happening. But several joints can make some kind of noise which is painless. And as long as it is painless, it may be just the way the knee, or as the wear and tear happens or whatever, it heals itself by forming some tissue, some fibrous tissue. So and that fibrous tissue can often create some kind of clicking, creaking kind of sound. But as long as you have a painless sound, I would sort of be fine if you ignore that. But if you have a painful click or painful creak, then you certainly need to sort of get yourself investigated.
Thank you. We have a question from Vaishali Prabhudesai, who's 75. The question is, does a flat foot have a bearing on knee pain problem? Does it cause knee pain or aggravate it?
So, see, any change in the way forces are transmitted up to the knee can affect the knee over a long period of time. So when you have a flat foot, the foot is typically pronated, which changes the amount of force that goes up onto the knee. Typically, the center of the ankle, the center of the knee, and the center of the hip should all be in a straight line. As long as they're in a straight line, the forces are transmitted equally. If any one of these changes, whether it's the knee turning into varus or it's the foot turning into pronating, or somebody developing a flat foot, it will change the axis that sort of carries your weight, and depending on which side the axis is shifting, one or the other compartment of the knee may be loaded more than the other, and over a prolonged period of time, this may lead to arthritic changes that can end up developing in the joint. So if somebody is symptomatic, we do recommend a footwear modification, sort of for a flat foot, maybe a medial arch support, to sort of get the overall alignment better.
A question, is it hereditary, osteoarthritis?
So osteoarthritis does have a genetic component, which means it is more common in people whose parents had osteoarthritis, but it is not directly, it's not extremely strongly linked. So it's not that if I have arthritis, then my kids are going to have arthritis, but the chances, it's a risk factor, it's an added risk factor to develop osteoarthritis in the future.
Right. We have a question from an anonymous attendee who says, I'm male 72 with osteoarthritis, unable to have surgery. Can he get by with medication? If so, what and for how long?
See, the only medications that help in osteoarthritis are painkillers. So as you change doctors and as you go and see somebody else, what does a typical prescription for osteoarthritis contain? It will advise physiotherapy. So first advice is weight loss. If there's one thing you can do to delay or prevent osteoarthritis, you need to manage your body weight. 1 kg of extra body weight transmits 8 kgs of additional stress on the knee. So if somebody loses 5 kgs of body weight, they actually lose 40 kgs of stress across the knee, which is immense. And put this together over years, the amount of benefit or the amount of unloading of the knee that weight loss can do is going to be significant. So the first, if there's one thing you can do, then that's managing your body weight. If there are 2 things you can do, then the second thing is strengthening the muscles around the knee. The stronger the muscles around the knee are, the less load will be transmitted onto the bones, and therefore the cartilage of the knee will survive longer. Now, when you come to the third option, which is what else can we do? So this is basically the crux. The only evidence-based 2 things that delay osteoarthritis is weight loss and physiotherapy or exercise. Now, other than that, the medication part in a prescription that is typically given will contain one or the other form of a supplement, like glucosamine, chondroitin sulfate. But honestly, if I go by evidence, then, and we look at American Academy of Orthopaedic Surgeons guidelines or NICE guidelines, which is National Institute of Clinical Excellence, UK, they have looked at this in a large subset of patients, and these guidelines state there is no role, and quote unquote, there is no role of glucosamine or chondroitin sulfate in the management of symptomatic osteoarthritis of the knee. So essentially, more and more studies are showing that these supplements that are given do not work effectively enough. Having said that, evidence is formed if, let's say, 6 or 7 out of 10 people benefit. If 2 people out of 10 benefit, it will still not form a guidance or an evidence. So you could always try with supplements and hope that they help pull on the knee for a longer duration. But other than this, the other medication that is written in a prescription is only a painkiller. And as you change doctors, the name of the painkillers change, but essentially the ingredients typically remain the same. There are certain safe painkillers, however, like paracetamol or Ultracet, which do not have an adverse effect on the kidney or the liver in regular doses. So these are safe painkillers. As long as they help you manage the pain, then that's all right. Other than this, there is an option of managing pain by giving intra-articular injections. So injection into the joint to help you manage and carry on with the arthritis. But essentially, the main things are going to be physiotherapy and managing the body weight, along with occasions when we might consider giving an injection into the knee.
Thank you, doctor. I do know that you have to leave. I'm going to ask you just 2-3 questions which are there, which are slightly different. With so much calcium that one has, this is DJ Santa Maria. What happens to the heart vessels? Could there be an impact on that?
So see, what we have to understand is that excess of calcium is bad, but we are talking about restoring the normal required calcium. So if we understand the mechanics of calcium, what we need to understand is that the bone is the bank for calcium. Okay. Now, whenever blood calcium levels drop, the blood borrows this calcium from the bone and restores its calcium levels. So if you do a blood test to check your calcium levels, they will always come normal. Because whenever the blood was deficient in calcium, it borrowed it from the bones, making the bones weaker. Therefore, if we want to see whether your bones are deficient in calcium or not, there is another test which is known as bone mineral density or bone densiometry or a DEXA scan. If you are deficient, if you are osteoporotic or osteopenic, then you do need calcium supplementation. This is to give enough calcium to the body that the body needs, not excess calcium. And that will allow the bones to retain the calcium that they need.
Right. Thank you. We have a question from an anonymous attendee who says, I'm 69, about 95 kgs. I walk 7 kilometers daily and climb 4 flight of stairs, that is 4 into 20, 80 steps daily. Would this in future give me some strain on the knees?
Well, if you, I mean, it's commendable what you're doing. I hope that when I get there, I'm able to do what you're doing. So congratulations for that. Having said that, if you don't have a problem in the knee at the moment, then I would not ask you to refrain from doing what you like to do and what you do. If you already have underlying osteoarthritis, then probably the only thing that you could alter or change would be the amount, is the stair climbing bit. But walking on level ground is a very, very joint friendly exercise. It is recommended even in bone on bone arthritis. We never ask you to stop walking. So please continue your walks. And if you have an intact cartilage at your age, I wouldn't even refrain you from sort of using the stairs.
Doctor, one last question that we are looking at, and there are quite a few questions. I'm going to request you to come here once again.
I would love to.
There's one question which is important, I think, is from Narendra Arora. What are the exercises that one shouldn't be doing?
So exercises can be divided into joint friendly exercises and joint unfriendly exercises. Now, let me tell you, so what are these exercises that are not good for the joints? Any high impact activity is not good for the joints. So jogging, running, high impact activities are not good. What are good exercises for the joints? So if you want to go to the gym and you want to cycle, it's a good exercise. If you want to use the elliptical or cross trainer, that's a good exercise. Walking is a very joint friendly exercise. Swimming is a very joint friendly exercise. So there are, except high impact loading activities, everything else does not harm your joints, irrespective of the degree or grade of arthritis that you have. So you're recommended to continue doing these exercises. If somebody asks me, and I'll sort of, it's important that this point goes across, there are patients who come to us and say, but will doing exercises make my arthritis worse? The answer is, your arthritis, if someone has arthritis, is probably anyways going to get worse as time progresses. And there's a quote that we use. It is better to wear your joints out rather than to rust them out. Okay, so arthritis will get worse anyways. The activities that you're able to enjoy today, please keep enjoying them. Just avoid high impact loading exercises that are going to make the joints wear out faster. Normal activities don't make the joint worse any faster, and they are recommended by all existing guidelines.
Doctor, it's 1 minute left. Can I just sneak in 1-2 questions?
Absolutely. Yeah, sure.
There's one person who's asked, can you sit cross-legged, or is it bad for the knees for a lady of 76? There's another person who said, my mother is 90 years old. Is it safe for her to go for a total knee replacement? She is in severe pain.
Okay, so which one should I take first? The first one, sitting cross-legged. See, we encourage you to take the knee through its range of movement as much as possible. When somebody develops arthritis, they have a tendency of the knee to stiffen up. So they will end up with inability to straighten the joint fully. It will be locked in about 5 degrees of flexion, and they lose the ability to bend the knee fully. So we encourage all patients to fully straighten the knee and fully bend the knee. Sitting cross-legged puts a little more strain or stress on the inner compartment of the knee. But if you ask me, as long as somebody is able to do that, I would, from my end, please continue doing it. It's important that you maintain the quality of life that you're maintaining for as long as you can. Coming to the next question about about whether a 90-year-old can undergo a knee replacement surgery or not. So, I mean, the answer to that is age as a number does not mean anything at all. I think the oldest patient we did a knee replacement for was 97 years of age. We recently did a replacement on an 84-year-old lady who was a doctor's sister. So age by itself is not a criteria. What is important is that if we have a 90-year-old who is fit in every regard for a surgical procedure, which means if the cardiac function is good, if the pulmonary function is good, if he's leading a very active life at 90, other than the knee pain, then looking at getting a knee replacement done to improve the quality of life of the remaining years is not a problem at all. But if there are physiological parameters that sort of put a 90-year-old as high risk for surgery, and if the sort of functional requirement is low, then I would recommend that we stay away from a surgical procedure.
Right. Thank you once again, Dr. Mudit Khanna, for this. You know, the thing is that like life is getting back to normal, so doctors have their OPDs and stuff like that. So which is why we are having some issues with our timings, but really thankful that you're here. And I would request you to come once again and speak to our people. I know there are quite a few questions that have come in and we have not been able to address all of them. So we will keep a record of them. And those of you who have registered here or rather who are present here, we will inform you once again when we have Dr. Mudit Khanna here. Thank you very much once again. And we will be back with a Health Live at Seniors Today session next Saturday at 5 p.m. Thank you very much.
Thank you very much. It was a pleasure to be a part of this, and thank you very much for inviting me over.
Thank you.
Thank you.